Muscle activity during functional coordinating training, implications for strength gain and rehabilitation. National Research Center for the Working Environment, Copenhagen, Denmark. Department of Exercise and Sport Sciences, University of Copenhagen, Copenhagen, Denmark. And Research Unit for Musculoskeletal Function and Physiotherapy, Institute of Sports Science and Clinical Biomechanics, University of Southern Denmark, Odense, Denmark. Abstract. Muscle activity during functional coordination training, implications for strength gain and rehabilitation. Journal of Strength Conditioning Research 24/7, 1732 through 1739, 2010. The purpose of the study was to evaluate if different types of body positions and levels of progression of functional coordination exercises can provide sufficiently high levels of muscle activity to improve strength of the neck, shoulder, and trunk muscles. 9 untrained women were familiarized with 7 functional coordination exercises 12 times during 4 weeks before testing. Surface electromyographic EMG activity was obtained from rectus abdominis, erector spinae, obliquus exterminus, and trapezius during the exercises with 2 through 4 levels of progression. Electromyography was normalized to the maximal EMG activity during maximal involuntary contractions, and a p-value of less than 0.05 was considered significant. All record muscles reached sufficiently high levels of activity during the coordination exercises for strength gain, greater than 60% of the maximum EMG activity. Type of exercise played a significant role in the attained muscle activity. Body position during the exercises was important for the activity of the erector spinae, and level of progression was important for the activity of the trapezius. The findings indicate that depending on type, body position, and level of progression, functional coordination training can be performed with a muscle activity sufficient for strength gain. Functional coordination training may therefore be a good choice for prevention or rehabilitation of musculoskeletal pain or injury in the neck, shoulder, or trunk muscles. Introduction. Muscle strength is important for the longevity of life without pain. Furthermore, strength training can be effective as treatment and prevention of musculoskeletal pain. Besides muscular strength, improved coordination skills may be critical for prevention of musculoskeletal pain. Persons with musculoskeletal pain are observed to have an impaired coordination compared with healthy control. Therefore, coordination exercises are generally recommended for preventing and reducing musculoskeletal pain. The main advantage of functional coordination exercises is that several muscle groups are simultaneously activated, reflecting the muscle activity pattern during daily work tasks, and might therefore function as a preventative strategy towards work-related pain. Moreover, the high muscle activation with less stress on joints and muscles during functional instability exercises is generally considered beneficial for general musculoskeletal health and rehabilitation. However, a limitation of functional coordination training is a lack of increase in muscular strength. If coordination training can be performed with sufficient intensity to also induce a strength gain, this may further enhance its value compared to other types of prevention and rehabilitation exercises for musculoskeletal pain and injury. A muscle activity level of 60% of maximum voluntary activity is generally considered necessary for gaining strength. Although a high level of muscular activity can be easily attained during traditional strength training by enhancing the external load, it is not so easily achieved during complex functional coordination exercises and conventional therapeutic exercises. This may explain the lack of strength gain from functional coordination training in previous studies. The muscle activity during functional coordination training can mainly be modulated by voluntarily activating the muscles more intensely for changing body positions, or by applying higher levels of difficulty progression in each exercise. However, activity of the neck, shoulder, and trunk muscles remain to be studied during different types of body positions and levels of progression of functional coordination exercises. The aim of this study was to evaluate if different types, body positions, and levels of progression of functional coordination exercises can provide sufficiently high levels of muscle activity to improve strength of the neck, shoulder, and trunk muscles. The hypothesis of the study were that A. The type of functional coordination exercises is important for the attained level of activity in the neck, shoulder, and trunk muscles, where some exercises evoke sufficient levels of muscle activity for strength gain, and B. The body position and level of progression of the functional coordination exercises are important for the level of activity in trunk, neck, and shoulder muscles. Methods. Experimental approach to the problem. For testing the hypothesis of the study, the activity in the neck, shoulders, and trunk muscles was recorded by surface electromyography, EMG, during functional coordination exercises of different types, body position, and levels of progression in women with musculoskeletal symptoms familiarized to these exercises. Subjects: 9 sedentary, untrained female workers, mean age 46 plus or minus 2.4 years, height 167 plus or minus 1.5 centimeters, weight 68 plus or minus 3 kilograms, were recruited from a daycare office. Neither of the subjects had a higher level of training background or any significance. They reported pain in the neck, shoulder, upper back, or lower back during the past year with a 10 centimeter visual analog scale. All subjects reported pain in one or more of the following body parts: neck, shoulders, and lower back, corresponding to an average pain reported of 2.3, plus or minus 1.0. The project was carried out in the spring through March. Appropriate information consent was gained from the subjects. The study was performed in accordance with the Declaration of Helsinki and approved by the local ethics committee, HC 2007-0033. Procedures. To attain valid and reliable information about levels of muscular activity during different types of levels of functional coordination training, the subjects need to be well familiarized with the exercises. Therefore, the subjects received instructions and practiced on the functional coordination exercises for 4 weeks before the muscle activity recordings were performed. The practice of the exercise consisted of 3 sessions of 20-minute durations per week. In figures 1A through G, the 7 functional coordination exercises with 2 through 4 levels of progression are illustrated. Level 1 is the most complex level of progression, with decreasing progression levels with numbers 2 through 4. That is the highest level of muscle activity. Was expected at level 1. 4 exercises, 4-point kneeling, prone, plank, bracing, and bridge were performed in prone or supine laying body positions, and horizontal side support was performed in sideways laying positions, whereas body blade exercises and vertical plank were performed standing. The spine and neck were held in an anatomically neutral position with shoulder blades neutrally protracted during all exercises. Participants were instructed to activate relevant muscles all out for 20 seconds during static exercises and for 8 repetitions during dynamic exercises. The dynamic exercises were performed in an even and controlled manner with a pace of approximately 2 seconds per movement and in the following order: 4-point kneeling, levels 3, 2, 1, prone plank, levels 4, 3, 2, 1, bracing, levels 3, 2, 1, body blade, levels 4, 3, bridge, levels 2, 1, vertical plank, levels 2, 1, horizontal side support, levels 2, 1, body blade, levels 2, 1. The subjects rested approximately 1 minute between exercises. Bracing. Bracing was performed with subjects supine on the floor with the hips and knees flexed at 90-degree angles and the feet on the floor, and at 3 levels of progression, figure 1A. At level 3, subjects focused on stabilizing the trunk by activating the abdominal muscles. At level 2, subjects dynamically extended their arms to almost 180 degrees extension. At level 1, subjects dynamically flexed the hips at 90 degrees flexion so the foot was lifted from the floor. Bridge. The subjects were supine on the floor with hips and knees flexed at 90-degree angle and the feet on the floor. The exercises were performed at 2 levels of progression shown in figures 1B. At level 2, the hips were dynamically extended at 20 degrees while the subjects focused on stabilizing the trunk. At level 1, the hip and knee were statically extended to 0 degrees, lifting the foot from the floor. 4-point kneeling. The subjects were prone in a 4-point stand with knees hip width apart and hands shoulder width apart and hips and knees flexed at 90 degrees, figure 1C. The exercise was performed at 2 levels of progression, with level 2 was performed with no dynamic movement, only focusing on stability of the trunk and shoulders, while one shoulder and the contralateral hip knee were simultaneously extended in level 1, so the arm and leg were horizontally stretched. Horizontal side support. Horizontal side support was performed in 2 different levels of progression, as shown in figure 1D. At level 2, subjects were in side laying position with only knee and elbow resting on the floor. At level 1, subjects were in side laying position with only one foot and elbow resting on the floor. Prone plank. Prone plank was performed at 4 levels of progression as shown in figure 1E. At level 4, the subjects were prone with their knees and hands on the floor, shoulder width apart. At level 3, subjects were prone on their feet and hands. At level 2, subjects dynamically extended one hip to lift the foot from the floor. At level 1, subjects dynamically extended their shoulder to lift the hand from the floor. Vertical plank. Subjects leaned forward with their hands resting on the wall, shoulder width apart, and their body approximately 70 degrees to the floor. Figure 1F. Shoulders were 90 degrees extended. The exercise was performed in 2 levels of progression. At level 2, subjects stood statically in this position, focusing on stabilizing the trunk and shoulders. At level 1, subjects rotated their feet 90 degrees in relation to the floor and performed a bilateral shoulder abduction at the horizontal level, so only one arm supported the body against the wall. Body blade. The body blade exercises were performed in 4 levels of progression. Subjects stood on both feet hip width apart as shown in figure 1G. Subject stood with the dominant shoulder at 90 degrees flexed position holding a body blade classic NMK import bring Iviz 1B DK-3500 Verlos, Denmark. Horizontally in their hand at level 4. Small extensions and flexions of the shoulder were performed to make the body blade oscillate. Level 3 was similar to level 4 with both hands holding the body blade. At level 2, the body blade was held by one arm in a vertical position. Small abductions and adductions of the shoulder and horizontal level were performed to make the body blade oscillate. Level 1 was similar to level 2 with both hands holding the body blade. Maximum voluntary contraction. To attain maximal levels of EMG activity for each muscle, isometric maximal voluntary contractions, MVCs, were performed in backward extension and forward flexion of the trunk and shoulder elevation in accordance to validated standard procedures. The subjects were verbally instructed and encouraged to slowly increase force, maintain a maximum level for about 2 seconds, and then slowly reduce the force. Each measurement of muscle strength was repeated 3 times with 30 seconds rest between, and if the force increased more than 5%, an additional MVC was performed up to a maximum of 5. Because of elevated blood pressures above 100 to 140 millimeters mercury, 3 subjects were excluded from the MVCs. Electromyography. Bipolar surface EMG electrode 6 millimeters diameter, Neuraline 725-01-K, Medicotest AS Rugenmarken 10 DK 3630, Ostke, Denmark, were placed on the skin with an intra-electrode distance of 2 centimeters of the dominant side according to standard procedures above the rectus abdominis, 3 centimeters lateral to the umbilicus. External oblique, 15 centimeters lateral to the umbilicus erector spinae, 3 centimeters lateral to the spine at the level of the crista iliac, and trapezius, 2 centimeters medial to the midpoint between the acromion and the spinous process of C7. The reference electrode was placed on the spinous process of C7. The EMG signals were sampled at 1000 Hz data logger technology, HB Sweden, amplified analog band pass filtered 10 through 400 Hz 8th order Butterworth, AD converted at 1 kilohertz and recorded on computer via a laboratory interface, CED 1401, Spike 2 software, Cambridge Electronic Devices, Cambridge, United Kingdom. The EMG amplitude was calculated by root mean square, RMS, with non-overlapping windows of 500 milliseconds. Start and end each repetition of all exercises were marked with a trigger. For the dynamic function coordination exercises, peak RMS EMG amplitude of each repetition was averaged from the first 4 repetitions of each exercise. The average of the first 4 repetitions of each exercises was done to get representative information of the maximum activity of each exercise. For static functional exercises, peak RMS EMG amplitude was averaged during the first half of the exercise minus the 2 seconds. The first half of the exercise minus the very first 2 seconds was used because of a very stable performance of the exercises in this part. During the MVCs, the peak RMS EMG amplitude with the time window of 500 milliseconds was calculated. Peak EMG mean SE trapezius 567.44 plus or minus 177.62 milliverts, erectus spinae 103.63 plus or minus 25.9 milliverts, obliquus externus 95.20 plus or minus 11.43 milliverts, rectus abdominis 83.29 plus or minus 15.20 milliverts. The RMS and EMG activity from each muscle during the functional coordination training was normalized to the peak RMS EMG activity of each respective muscle from each respective subject during the MVCs. This was performed to attain the relative activity of each respective muscle during the functional coordination exercises. All tests were performed in the midday or afternoon, and the subjects were informed to eat and drink appropriately before the testing. The subjects were offered water during the testing. Statistical analysis. Analysis of variance for each muscle and Tukey-Kramer's post-hoc tests were used to test differences in muscle activation between the different exercises. From each type of exercise, only the progression level with highest muscle activity was applied in the test. General linear model was used to test the effect of level of progression. And Tukey-Kramer's post-hoc test was used to specify differences. An adjusted p-value of less than or equal to 0.05 was used as level of significance. Results are presented as mean plus or minus SE. Statistical analysis were conducted with an SAS version 9 SAS Institute Incorporated 100 SAS Campus Drive, Cary, North Carolina, 27513 through 2414. Because 3 subjects were excluded from the MVCs, the descriptive statistics on the normalized EMG activity were based on 6 subjects. However, all statistical tests were performed on absolute EMG values of the 9 participating subjects with within-subject comparison only. All difference of less than 15% between exercises was considered clinically insignificant. This was based on recommendations from general strength training literature, e.g. recommendations on hypertrophy 70 through 85% of 1 repetition maximum, RM, or muscular power 85 through 100% of 1 RM. Power analysis made before the study showed that 8 subjects in this paired design were sufficient to obtain a statistical power of 80% at a minimal relevant difference of 15%, a type 1 error probability of 1%, and assuming a standard deviation of 10% based on previous research in our laboratory. Results. Exercise type and activation above 60% maximum voluntary contractions. As illustrated in Figure 2A through D, the type of exercise had significant impact on the level of activity of the different muscles, P of less than 0.05. The average activity of the muscles studied during the different functional coordination exercises is illustrated in Figures 3A through C. As illustrated in the figure, depending on exercise, the level of progression, all muscles reach the level of activation above 60% EMG max. For the upper trapezius, activity above 60% EMG max was reached with horizontal unilateral body blades 73.9 plus or minus 5.1%, and horizontal bilateral body blade exercises 84.9 plus or minus 7.5%. Erector spinae exceeded 60% MVC in 4-point kneeling, 79% plus or minus 11.7%. Horizontally bilateral body blade 77.7 plus or minus 8.1%. Bridge 76.3 plus or minus 6.3. Horizontal side support 71.6 plus or minus 10.2%. And vertical bilateral body blade 71.7 plus or minus 7.3. Obliquus externus exceeded 60% MVC in prone plank level 1, 124.2 plus or minus 24%. Prone plank level 2, 88.9 plus or minus 22.4%. And horizontal side support 64.9 plus or minus 7.8%. Rectus abdominis reached the 60% MVC level in prone plank level 1, 87.7 plus or minus 10%, and in horizontal side support 70.1 plus or minus 10.1%. Body position. For the erector spinae, the standing and sideways exercises resulted in a higher activity, 36.7 through 90.5 millivolts, in comparison with the prone and supine exercises, 19.2 plus through 71.8 millivolts. P is less than 0.05. Body position did not have any significant effect on muscle activity for any other muscles. Exercise level progression. The level of progression generally played a significant role for the level of muscular activity. P is less than 0.001, but based on the post hoc test, this was only significantly so for the trapezius muscle. For the trapezius progression of the prone plank from levels 4 through to 1, P is greater than 0.001, and 3 to 1, P is less than 0.001, significantly elevated the activity. There was a tendency to a difference between levels 2 and 1, P is equal to 0.05. Trapezius activation significantly increased from levels 2 through 1 of the 4-point kneeling, P equals 0.03. For the vertical plank progression from levels 2 through 1, increased the trapezius activity, P equals 0.01. For the body blade exercises, the different levels of progression provided different trapezius activation, in which level 4 provided higher activity than level 1, P equals 0.02. The levels of progression of the bridge horizontal side support and bracing, illustrated in 3A, did not play a significant role for the trapezius activity. Rectus abdominis muscle activity. By far, the highest activation of rectus abdominis was found during prone plank and horizontal side support, figure 2A. Prone plank activated the rectus abdominis significantly more than the rest of the muscles except horizontal side support. Horizontal side support resulted in significantly higher rectus abdominis activity than the remaining exercises. Among the remaining exercises, no differences in rectus abdominis activity were found, but vertical plank provided the lowest activation. Erector spinae muscle activity. Bridge, horizontal side support, and 4-point kneeling resulted in the highest activity of the erector spinae. The activity during these exercises was significantly higher than in prone plank and bracing, figure 2B. Body blades showed a significantly higher activation level than bracing. Moreover, vertical plank showed a significantly higher erector spinae activation than bracing, providing the lowest erector spinae activity. Obliquus externus muscle activity. As shown in figure 2C, prone plank resulted in the highest obliquus externus activity, being significantly higher than all other exercises. The level of obliquus externus activity during prone plank was followed by horizontal side support, being significantly higher than the rest of the exercises except body blade. Between the remaining 5 exercises, no significant differences in obliquus external activity were found. Bracing through resulted in the lowest activity of obliquus externus. Trapezius muscle activity. As seen in figure 2D, the highest activity of the trapezius was found in prone plank and body blade. During these exercises, the trapezius activity was significantly higher than during bridge, horizontal side support, and bracing. 4-point kneeling resulted in higher trapezius activation than horizontal side support and bracing. Vertical plank activated the trapezius significantly more than bracing. The lowest trapezius activity was found during bridge, horizontal side support, and bracing, in between which no significant difference in level of muscle activity was found. Discussion. The main findings of the study were that untrained women can attain significantly high levels of activity in neck, shoulder, and trunk muscles for strength gain during functional coordination exercises. However, the activity of the respective muscles depend on type, body position, and level of progression, the functional coordination exercises. A novel finding of the study was that muscle activity during functional coordination exercises depend on type, body position, and level of progression within each exercise. As we hypothesized, the type of exercise was important for the attained activity of each respective muscle of the neck, shoulder, and trunk. The significantly different activity of the recorded muscles during several of the functional coordination exercises illustrates the need for prescribing specific exercises for specific purposes. Therefore, the result of the study may be useful in designing specific exercise programs based on functional coordination training for populations with need for strengthening neck, shoulder, and trunk muscles in a controlled and functional manner. Because several exercises generate sufficiently high levels of muscle activity for strength gain in most of the recorded muscles, other considerations can be brought into play when deciding which exercise to use in an individualized clinic exercise program. For example, the exercise prone plank and horizontal side support provided very high activity of the abdominal muscles. The bracing exercise, which is also often applied exercise for the abdominals, generally resulted in low abdominal activity, 10 to 20% of maximal, and cannot be considered a strengthening exercise for untrained subjects. Exercises involving isometric muscle contractions without external resistance are earlier shown to generate insufficient levels of muscular activity for strength gain. However, the bracing exercise may still serve a purpose in the early part of the training program, where the goal is to improve the ability to contract the muscles without an external resistance. For example, after cesarean section or other kinds of open surgery involving the abdominal wall. The normalized EMG data indicated that functional coordination exercises can activate trunk and shoulder muscles above the level required for strength gain in untrained workers with musculoskeletal symptoms. Although previous studies have shown improved coordination after coordination training, the present study indicates that this type of training can be used to stimulate gains in maximum strength capacity as well. This findings support that functional coordination training may be particularly appropriate for populations with high incidence of musculoskeletal pain and injuries like workers with high physical demands or an athlete population. For example, the body blade exercise activates the often pain-afflicted erector spinae and trapezius muscles to sufficiently high levels for strength gain. Moreover, the high muscle activity of the trunk and shoulder muscles during the controlled functional exercises also indicates that they may be suited for injury prevention, rehabilitation purposes, and strengthening of the trunk and shoulder muscles for an athlete population. Previous studies evaluating activity of neck, shoulder, and trunk muscles during functional coordination exercises have shown correspondingly high levels of muscle activation as shown in the present study. However, these exercises were performed by younger or well-trained non-symptomatic subjects with a lower level of muscular activity, 45% of the maximal considered necessary for gaining strength. Body position during the functional coordination exercises was of importance for the erector spinae muscle. The erector spinae was activated to a large extent during standing and sideways exercises than during prone or supine positions. This indicates that functional coordination training for improving strength in the erector spinae muscle may be most appropriate to perform in a standing or sideways position. Moreover, the level of progression during the functional coordination exercises was shown to be of importance for the attained level of activity of the trapezius, but not for the other recorded muscles. Traditional increases in level of progression in prone plank, 4-point kneeling, and vertical plank increase the trapezius activity. The level of progression with body blade exercises also played a role for the trapezius activity as shown in Figure 2. The unilateral horizontal body blade exercise resulted in the highest trapezius activity. A strength of the study was that the subjects were untrained women with musculoskeletal pain, and they were thoroughly familiarized with the exercises before the evaluation of muscle activity. A limitation of this study was that only sedentary women participated in the study, and the findings may therefore not be representative of a male or athlete population. Although the number of subjects may seem low, power calculations supported the number of the subjects provided a sufficient power for the analysis. The applied bipolar surface EMG with an intertrode distance of 2 centimeters provided only a few centimeters pickup area of muscle activity. This not only avoids significant levels of crosstalk from neighboring muscles, but also means that muscle activity from deeper muscles involved in the functional coordination exercises were not recorded. Practical applications. Depending on type, body position, and level progression, functional coordination exercises can generate sufficient levels of activity of neck, shoulder, and trunk muscles for strength gain. When taking the type, body position, and progression into consideration, functional coordination training may be a good choice for the prevention and rehabilitation of musculoskeletal pain and injuries, and an appropriate means for strengthening the neck, shoulder, and trunk muscles in a controlled and functional manner. The subjects practiced on the functional coordination exercises for 4 weeks for being well familiarized with the exercises before the testing of muscle activity. We would like to mention that the different complexity of the coordination exercises may provide different learning curves by all subjects learned to correctly perform all exercises within the 4 weeks of practice. Consequently, individually tailored functional coordination exercises may be well suited for both improving strength and coordination, and therefore be well suited for several populations with high incidence of musculoskeletal pain and injuries, like workers with high physical work demands or an athlete population. Acknowledgements. We would like to thank Henrik Bader Olsen for the outstanding technical support in both data collection, procedure, and data processing. Furthermore, Martin Ludgren Jensen is thanked for enthusiastic instruction of the subjects during the training period and during the test. We declare that there is no conflict of interest. This study was supported by a grant from the Ministry of Cultural Committee on Sport Research, Denmark, and conducted as part of the Finale program supported by the Danish Working Environment Research Foundation.